So what now Abhijeeva had given you an overview into what primary survey is, what secondary survey is, and additional things or specific things that you would need to do during primary and secondary surveys. It's kind of an overview. So now what I will do is I will take you through airway breathing and circulation, because we have a limited amount of time, in relation to specific things that you would do during the assessment of specifically airway and then breathing and circulation, and what are the problems you may find, the common issues, and what are the things that you can do for these patients. And also I have shared with you some of the skills that you may have to use during the assessment and interventions during these ABC assessments. Okay, so airway is most important. Abhijeeva had already highlighted you, because once airway is blocked, you can't do anything. Think of a situation like that. A young male motorbike accident, you can see the face is completely crushed. He's intoxicated. Now he has a low saturation. So most likely in this situation, his low saturation is due to a reduction in or obstruction of his upper airway. So these are the things that we will try to cover during this next 20 minutes also. Just right. So you need to be able to recognize the signs and symptoms of airway obstruction. This patient, obviously, the features are suggestive of airway obstruction. And then the techniques that are available. So I have shared some of the videos of establishing airway, including bag and mask ventilation, nasopharyngeal, oropharyngeal airways, and endotracheal intubations, different techniques of establishing upper airway, and how to check once you have established the airway, how to check whether the established airway is adequate in maintaining ventilation and oxygenation. These are the things that you need to know. So the first question is, when a patient is brought to A&E, or when you see a patient who is brought after trauma, whether the airway is adequate. How do you know whether the airway is adequate in a patient? Anybody? In ATL
saturation, sir.
First thing is you talk to the patient, right? If the patient is talking, if the patient talks back to you, that means the airway is open. If the patient is not talking, then you have to take it from there onwards. First, you go immediately. Now, Abhijeeva also, I think, highlighted you. You go and talk to the patient. That is the first thing that we do in trauma. So if somebody talks rationally, that tells you the airway is straight and he's breathing, the brain is getting oxygenated, there is some degree of perfusion as well, which may not be enough, or he may not be able to continue, he or she may not be able to continue, but we know for that given a point of time, all these are at least somewhat okay, especially the airway is okay, right? So if the patient is normal, talking normally, he's alert and oriented, then we know his airway is okay. But in a patient like the previous picture I showed you, if there are significant facial injuries or there are other situations that we will discuss a little later, you may suspect that there could be problems with airway later on. Right. So signs and symptoms of airway compromise: change in voice, sore throat, noisy breathing, and based on the circumstances, like if the patient has been extricated from a place where there had been a fire, you may expect some inhalational injury and possible upper airway obstruction, potential upper airway obstruction. So all these are some symptoms and signs to suggest that the patient could be developing or has already developed upper airway obstruction. So when would you intervene? Every patient, Abhijeeva also highlighted, as soon as a patient is brought in, what you would do is keep the patient on high flow oxygen, because oxygen is not going to kill anybody, it's not going to do any harm. Okay, there may be a shortage of oxygen these days, but in general, there is no shortage of oxygen. It will not do any harm. So every patient should be on oxygen. But when would you decide, or how would you decide whether the patient requires an additional airway support? Right. So if the patient has a problem, airway obstructed, then of course you need to establish the airway. If the airway is already obstructed or impending airway compromise, based on the things that we have already discussed, then again you need to establish airway. and the patient has a breathing problem, where you need to ventilate the patient. Again, without an airway, you can't ventilate a patient effectively. And third category would be where the patient has a problem in maintaining the airway. That's a problem with disability. Anybody with a GCS of less than 8, patient requires intratracheal intubation and ventilation, because otherwise the patient cannot protect his or her airway, and they have a significant major risk of aspiration and further complications. So methods to manage upper airway. So first thing I've already told you, supplemental oxygen every patient. Then there are basic techniques. Can anybody mention the techniques, basic techniques of opening up the airway?
Chin lift and jaw thrust.
Yes, we don't do that full triple maneuver, that is head tilt we don't do, but chin lift and jaw thrust are the basic measures that are available. So basic techniques, but in every patient those won't work. So then you'll have to go for additional adjuncts. You have seen some of the videos like nasopharyngeal, oropharyngeal airways, etc. In some patients, even that is not enough. Then you have to go for a definitive airway, that is a cuff tube below the vocal cords, where the airway is completely protected, plus you can provide ventilation through this particular airway. So those are the 4 methods, or rather 3 methods of establishing upper airway. So airway management make sure that you always protect the cervical spine. You can see the assistant is protecting the cervical spine while the other person is trying to establish the airway. So every patient you need to treat as though the patient is having a cervical spine injury, unless proven otherwise. So chin lift, you know how to do the chin lift. Hope you all have practiced these things in mannequins in the accident service. You pull the chin forwards, upwards. Chin lift is lifting the chin up while hooking the fingers underneath the chin. Here what you are trying to do is you are trying to pull the tongue forwards. So if the tongue has fallen back and is obstructing the airway, this maneuver will help open up the airway. And then jaw thrust, that again works pretty much a similar way. You are pulling the jaw anteriorly by keeping your fingers behind the angle of the jaw. This again will open up the upper airway. Head tilt is not done in trauma because you may aggravate a cervical spine injury if one exists in these situations. Right. So you may do the things, the chin lift and the jaw thrust, but still if you feel that the airway is not adequate, then you need to go for basic adjuncts in establishing the upper airway. Oropharyngeal and nasopharyngeal airways are the 2 commonest things that we use. Most probably oropharyngeal is the more common one. Here, of course, you need to remember a conscious patient will not tolerate a oropharyngeal airway. So a patient who is unconscious is the ideal patient where you can insert an oropharyngeal airway to make sure the airway is kept open, especially if the tongue is falling back. Oropharyngeal airway is the ideal. So again, if you remember just now I told you, anybody with a GCS of less than 8 should get a proper upper airway, that is a definitive airway, that's an endotracheal tube with cuff below the vocal cords. If you can use oropharyngeal airways only in patients who are unconscious, then those are the very same patients who will require a definitive airway as well. So until the definitive airway is established, we can use a oropharyngeal airway as a temporary measure. Right. So the definitive airway, I have already mentioned what the definitive airway is. But in some patients, like the patient that we saw right at the beginning with a crushed face, you may not be able to use any of the airways that we discussed previously, because now the patient has a problem in the face. So you can't use a nasopharyngeal airway, you can't use oropharyngeal airway, you can't use endotracheal tube. In such a situation, if you find the patient saturations are dropping, patient is going into upper airway obstruction, you need to establish a surgical airway. There are 2 main types of surgical airways. One is called cricothyroidotomy. Second one is tracheostomy. So in trauma, however, we prefer cricothyroidotomy because it's a very simple procedure. Hope you all would have gone through the videos I have sent you yesterday. It shows you how to do a needle and a surgical cricothyroidotomy. It's a very simple maneuver which you can do within a few seconds. Anybody should be able to do this maneuver within a few seconds and establish an upper airway with minimum bleeding and complications. Whereas if you try to do a tracheostomy, it's a far more complex procedure. There's a lot of bleeding, very difficult procedure in an emergency situation especially. Therefore, we always prefer to do a needle which gives you only few minutes of time, and is then followed by a surgical cricothyroidotomy that will establish the upper airway. Of course, this is not a permanent airway. You can keep it only for about 24 hours because after that it causes complications. But up to 24 hours, you can keep the surgical cricothyroidotomy. Right. So the next question is, once you get a tube in, whether be it an endotracheal tube or a tracheostomy tube, etc., how do you know whether you have got the tube into the correct place, whether it has gone into the esophagus, etc.? So you should see when every time you insert, especially the endotracheal tube, you should see it going through the vocal cords. Then after that, when you're ventilating, you should see the chest moving, auscultation. There should be breath sounds on both sides of the chest. If you have a ETCO2, you should see the pattern. I hope you know what the pattern is. In the theater, hopefully you have seen all these things. And the pulse oximeter should give a good reading, anything about 95%. And finally, the X-ray would confirm later. Right. So the same patient that we have discussed previously, 34-year-old motorcyclist. So what should we do now? We need to establish the airway. You can see his face is completely crushed. We have two options. Anyway, we have to protect his airway. We need to establish the airway. We can think of for endotracheal intubation, but endotracheal intubation is going to interfere with the management. Plus, it's going to be quite difficult in this patient. So most likely, this patient would benefit from a airway, so a surgical airway, either a cricothyrotomy depending on the situation, or tracheostomy depending on the circumstances. So since already the saturation is 85%, most likely need to tracheostomy later. Right. Any question? Sorry, airway management. How to assess and how to manage. Okay, since there are no questions, so you need to suspect airway compromise in all patients, especially if the patient is multiply injured. Initial assessment is out, but if the patient is not talking, then you need to think of potential upper airway obstruction. At the same time, you need to always treat these patients as having a potential cervical spine injury. We have discussed the place of adjuncts or various gadgets that are available for establishing an airway, and what a definitive airway is, and the usefulness, why we need to do use a definitive airway, and what are the circumstances. And then once we have established a definitive airway, how to assess whether the airway is in correct place. So that's about airway management. Now we will go into problems with breathing. Right. Think of a scenario like this. Again, a young man. Right. He was unrestrained drive in a high-speed frontal impact collision. Blood pressure 90/70, heart rate 110, respiratory rate 36 per minute. GCS 15. So he's talking. Patent airway. Why do you think he has potential breathing problems or injuries to the chest? And then how would you evaluate? Are the two things that you need to think. So this patient, we know for the moment, at least the airway is patent. His GCS 15, he's talking. But his breathing and circulation, there could be issues. So how would you assess this patient, and why do you need to suspect? Right. So these are the things that we will cover during next 15 to 20 minutes. Identify and initiate treatment during the primary stage of injuries that affect the airway and breathing. That is airway obstruction, tension, open pneumothorax, flail chest, and pulmonary contusion, massive hemothorax, cardiac tamponade. These are the things that we will cover. Then we will also discuss what are the commonly talked about 8 potential life-threatening injuries and what is the management of those injuries. There are 5 or 6 immediate life-threatening injuries, and there are 8 potential life-threatening injuries when it comes to thoracic injuries or breathing problems. So immediate life-threatening injuries are these 6: airway obstruction, tension pneumothorax, open pneumothorax, flail chest and pulmonary contusion, massive hemothorax, and cardiac tamponade. These are the in a person who has had a chest injury to the chest. These are the 6 immediately life-threatening injuries. Within few minutes, these can kill the patient. So these are some of the injuries that requires urgent intervention, immediate intervention that could save the lives of these patients. So what happens when somebody has a chest injury? The patient is not ventilating adequately because there isn't enough air getting into the chest, because either the airway is obstructed or because the lung is collapsed or lung is compressed. So inadequate ventilation will lead to hypoxia. The body is not getting enough oxygen now because the lungs are not getting adequately ventilated. So hypoxia leads to acidosis because at tissue level, tissues are not getting enough oxygen. So therefore, unless you correct this within a few minutes, this will be lethal. So that is why you need to recognize and do it immediately. So when would you suspect thoracic injuries or injuries to breathing problems? If the patient has tachypnea. But these are not very specific. Tachypnea may occur even in a patient with a circulatory problem or massive blood loss. But in a chest injury, patient with chest injury, so when there are breathing problems, again, you will see these. Tachypnea, respiratory distress, usage of accessory muscles, patient with hypoxic, trachea may be deviated to one side. You might hear abnormal breath sounds, so the breath sounds may be absent in one side. Percussion may be hyper or hyporesonant. And in some patients, you may see a chest wall deformity, or you might see open wound in the chest. All these are potential things that you might see in a patient with a chest injury. Right. So we will go through the 6 injuries one at a time. The immediate life-threatening injuries. Airway obstruction happens when there is a tracheobronchial injury, direct trauma to the neck. So management is immediate intubation of such patients. So I have excluded that. And after that, next one is tension pneumothorax. I'm just assuming that you all have gone through all these yesterday. I'm just going to quickly go through because we have a lot of things to cover. In a tension pneumothorax, what happens is there is an injury either in the chest wall or in the lung where air or gas leaks into the pleural space through a one-way valve. It could be coming from the chest wall or through the lung. Air gets collected inside the pleural space, compressing the lung, ipsilateral lung. As more and more air gets collected, because of the flap valve effect, it starts pushing the mediastinum to the opposite side. So the trachea would be deviated to the opposite side. This deviation causes compression, one thing, compression of the opposite lung, and second thing, it reduces the venous return due to kinking of the great vessels or superior and inferior vena cava. So patient if you have distended neck pains, deviated trachea, and then hypotension. All these are features of a tension pneumothorax, right? Breath sounds of the ipsilateral side would be absent because there's no gas exchange happening in that side, or there is no ventilation, and the percussion note will be hyper resonant. So the management, you know, all of you all know, immediate needle decompression. No x-rays, nothing. This is a clinical diagnosis. You insert a needle either in the second intercostal space or in the safe triangle, a large bore cannula, then that will give you few minutes to deal with the patient. So the definitive management is after that insertion of a IC tube. So this is a patient with a tension pneumothorax. You can see already the needle decompression had been done. You see the needle on the chest, and then the definitive management is insertion of a IC tube. Patient is conscious. You can see here the patient shouting. So this is going to save this patient's life. So insertion is made in the safe triangle, and then blunt dissection with a finger, you get into the pleural space, and then the IC tube is inserted into the pleural space. So you see, it takes only a couple of minutes. So immediate needle decompression followed by insertion of a IC tube, which is going to deal with all these problems. This IC tube should, I guess you all have seen IC tubes. It is connected to underwater seal bottle. That will work as a one-way valve. So the whatever they are that has got collected inside the pleural space would drain through this IC tube, and the lung will re-expand. So that will save the life of this patient. It's an intervention that all of you all should be able to do within a couple of minutes, and that will save the life of the patient. So the two important things: first thing, you need to suspect. Second thing, you need to be able to quickly clinically diagnose that the patient has a tension pneumothorax. Then you should be able to insert the IC tube after the needle decompression. Okay, that is tension pneumothorax. Second one is open pneumothorax. Here you see patient has an open wound in the chest, right? So what happens is every time patient tries to breathe, air comes through the path with the least resistance or the lesser resistance. So the air will get sucked in through the chest wall wound without coming through the trachea, bronchi, bronchioles, etc. So the ipsilateral lung will not get ventilated. So every time the patient takes a breath, patient needs to breathe in few liters of air. That causes a few hours or few minutes later, patient will go into a type 2 respiratory failure. What is the management? Immediately you need to cover the wound with a 3-sided plaster, addressing with plasters on 3 sides. Here you see this patient has an open chest wound and this plaster had been applied. Can you see the air escaping out from the bottom end? But air cannot get sucked in now. Right? So this is what you call a dressing with a plasters on 3 sides. Whatever you have available, it can be the glove, a piece of polythene, whatever, just keep it over the wound, apply plasters from 3 sides, that will correct the problem. So this will act as a one-way valve now. Air can escape, but air cannot come in. So gradually, the collapsed lung will expand, the work of breathing will come down, but the definitive management is you need to get IC tube. But as a temporary measure, either in the field or as soon as a patient is brought to the hospital, this will save the life of the patient. Okay, that is about open pneumothorax. So the third one is flail chest and pulmonary contusion. Here what happens is there's a significant direct trauma to the chest wall causing fracture of multiple ribs at multiple places. What we say is more than 2 ribs at more than 2 places. So there is a flail segment or a free segment that is floating. There are multiple problems. One is this segment will move in the opposite direction, because if you remember, we breathe by creating a negative intrathoracic pressure. So every time you create a negative intrathoracic pressure by expanding the lung, this floating segment will get sucked in. Right? So inspiration, when you try to open up your chest, this part will get sucked in due to the negative intrathoracic pressure. So the work of breathing is going to be more because of this paradoxical breathing. In addition to that, now for somebody to have suffered this type of a fracture, there should have been significant trauma with movement of a segment of the chest wall into the lung, onto the lung. So that would have caused a significant underlying pulmonary contusion. That is why we always say flail chest and pulmonary contusion, both go together. So flail chest, the mechanism of breathing is one problem, plus there is a significant underlying pulmonary contusion. Combined together, this will cause a significant hypoxia with potential for complications later on. So we need to ensure the patient is giving adequate amount of oxygen, very good analgesia, either thoracic epidural or intercostal block to minimize bleeding. Otherwise, it's very painful. Patient will not breathe adequately because of the pain. And we need to give adequate physiotherapy for the patient's lung to expand. If the lungs don't get expand, if the patient is becoming hypoxic, then we need to provide them with positive pressure ventilation, which is not mandatory. We try all that, all the other things that you have discussed, like analgesia, breathing exercises, oxygen. But if it doesn't work, patient has to be ventilated, intubated, and ventilated. Then the fourth condition that we are discussing is a massive hemothorax. Here there has been bleeding with a collection of large volume of blood in the ipsilateral hemithorax. So the patient will present with features of both hypoxia and hypovolemia due to the blood loss. Right? Patient will be tachypneic, dyspneic, hypotensive, tachycardic, plus ipsilateral chest movements will be less, percussion not will be hyperresonant, auscultation, there will be reduction in breath sounds, or there will be absent breath sounds on the ipsilateral side. Right? So plus the patient will be, as I discussed, patient will be in shock. Immediate management is you have established airway, then breathing, you have found there's a problem. Immediate IC tube insertion is a management. So we call it massive hemothorax when the initial drainage is more than 1,500 milliliters. So now there are two problems. One thing in this patient, one is inadequate ventilation, other thing is volume loss. So we need to correct both immediately. So IC tube will correct the chest expansion and ventilation, but you need to give fluids and blood for this patient because to correct the fluid deficit. So it's a class 3 hemorrhage, which we will discuss later. More 3 or more class 3 or more hemorrhage. So patient needs immediate blood, plus most likely this patient will require surgical intervention to control the bleeder. Okay, cardiac tamponade. Cardiac tamponade is when there is blood inside the pericardial space. The issue here is there had been bleeding mainly from the epicardial vessel or pericardial vessels. There is a small volume of blood, few milliliters, maybe 10 or 20 milliliters of blood. But what it does is, every time the heart beats, it will pump less volume of blood as compared to a normal person. If a normal person can pump 50 or 60 milliliters of blood, this patient will pump 20 milliliters less, though the amount of blood in the pleural pericardial space is very small. So they will have a very ineffective cardiac output, leading to shock. Venous drainage is reduced, therefore they will have distended neck veins. Plus, when you auscultate, they will have muffled heart sounds, so what you call Beck's triad: distended neck veins, muffled heart sounds, and hypotension. Based on those, you need to be able to diagnose a cardiac tamponade. In addition to that, a fast scan in most situations can confirm the diagnosis of cardiac tamponade. You will see a thin rim of blood, a black colored layer just outside the heart. This is the heart, this is the pericardium, and in between the two layers, you will see a layer of blood. If you see that, you know this is a patient with a cardiac tamponade. If you see this at NHSL, what you need to do is immediately you need to contact the cardiac surgeons. They need to come and do a thoracotomy and open the pericardial space and control the bleed. But if you are in a peripheral hospital where you don't have access to cardiac surgeons, then as a temporizing measure, you can do a aspiration of the pericardial space. Again, I have sent you a video where the technique of pericardial aspiration is shown. But the problem is, this blood is already clotted. This is not liquid blood, it is clotted blood. So very unlikely that the needle aspiration will remove all the blood. Having said that, even removal of few milliliters of blood will increase patient's cardiac output. So you may try that, but remember, it is not a definitive measure. It is not going to work all the time. If you have facility, if you have access to cardiac surgeons, that is a management. But if the cardiac surgeons are not there, in most of the hospitals, they do not. So you can aspirate and send the patient, transfer the patient immediately to a place where there is a cardiac surgeon or thoracic surgeon available. Right. So we have gone through the immediate life-threatening injuries. Then from there, we come into potentially life-threatening injuries. These will not kill the patient immediately, but if we don't attend to these and correct these will kill the patient few hours to few days later. Immediate life-threatening injuries, you have few minutes only, like tension pneumothorax, open pneumothorax, massive hemothorax, all those, you need to attend to the patient within a few minutes and correct that. Here, these injuries, we have a couple of hours or few hours, or sometimes few days before the patient dies of these problems. So we will briefly go through how to identify and what to do for these 8 potentially life-threatening injuries. Immediate life-threatening, no two questions, you should be able to manage them. These are recognition and then maybe transfer. So some of these injuries, you may not be able to immediately identify based on the clinical assessment alone. So you may request adjuncts or additional tests to confirm the diagnosis. So the commonest one that we use is a chest X-ray. So all multiply injured patients should get a chest X-ray on admission. If you remember, Abhijit, I told you, patient should never go to the X-ray department. The X-ray should come to the patient. Plus, all these patients get a fast scan done, focused assessment of sonography in trauma. It's a focused area. We look at the pericardium, we look at left upper quadrant, right upper quadrant, and the pelvis, and extended ones, we look at the lungs to see whether there's a pleural effusion or a pneumothorax. Additionally, ECG, arterial blood gas, pulse oximetry also will tell us whether this patient is adequately getting oxygenated, ventilated, and what is the cardiac rhythm and what is the saturation. So all these will help us in making diagnosis and making decisions. A simple pneumothorax. Problem here is, now there is air inside the pleural space, maybe with a collapsed lung, there is no pressure, there is no tension, unlike in a tension pneumothorax. So venous return is pretty much normal. So examination, you find ipsilateral reduced chest movements and hyperresonant percussion note and absent breath sounds. Patient will not die immediately, but work of breathing is increased and the patient may be hypoxic. So unless you diagnose this and insert a tube thoracostomy or IC tube, patient might become hypoxic and die later. So the definitive management is an IC tube. Then pulmonary contusions we discussed previously with Flail chest. Again, the management is provide the patient with good analgesia, oxygen, chest physiotherapy. But if the patient is not improving or if the patient is hypoxic, then patient requires intubation and ventilation. Another thing, now Abhijit also touched upon this topic of balanced resuscitation. Earlier, we used to give large amounts of fluids to each and every patient. Now we know giving large volumes of fluid is as bad as not giving fluids. So we try to group what we call balanced resuscitation. We try to give the minimum amount of fluid to maintain the minimum blood pressure that is required to maintain the perfusion of organs. Because especially in a situation like this, where you can see on the left side, there's a large area of lung contusion. In a patient like this, if you give large volumes of fluids, that will worsen the problem and patient may become more hypoxic. So fluids actually can heal this patient. So we need to ensure we keep the patient relatively dry as compared to any other patient. Okay, this is a non-massive hemothorax, or what you call a simple hemothorax or hemothorax. Here there is bleeding, but the volume of blood is less than 1.5 liters. And in most situations, the bleeding has stopped. So just a tube thoracostomy or IC tube to evacuate the blood alone is enough for management of these patients. In a hemothorax, we always insert IC tube, and because we want to drain the blood, because we know if we leave blood inside the pleural space, this blood, one thing can lead to infections, then it can lead to inflammation and fibrosis of the lung. To prevent all these longer term complications, we always insert an IC tube to these patients. Right. Diaphragmatic injuries. Diaphragm can get injured either due to blunt or penetrating trauma, commonly in the left side because right side is protected by the liver. Therefore, right-sided diaphragmatic injuries are relatively rare as compared to the left side. So blunt injury is when the abdomen gets crushed. Due to the increase in pressure, there may be a large tear in the diaphragm. Again, the right side is protected by the liver, common in the left side. Penetrating injuries is due to stab injury or a gunshot injury. If the injury, the agent goes through the diaphragm, then that will cause a diaphragmatic injury. But generally, those are tiny injuries. Most of the time, they are missed. They are detected only during the surgery, because penetrating injuries means most of the time the patient will undergo an open thoracotomy or a laparotomy. During that only these perforations are identified due to penetrating trauma. Blunt ones are identified mostly on X-ray. You find the bowels inside the chest wall, chest cavity. Fractures, there isn't anything much. The sternum, scapula, and rib fractures are commonly due to direct trauma. One thing that you need to remember is if there are fractures of especially first to second ribs, that indicates severe trauma, because those are very rarely fractured. That indicates the potential to have a major neurovascular injury in addition to the rib fractures. 4 to 9 are the commonest fractures that you see every day. Management is essentially pain relief and physiotherapy. Lower ribs. You know, the lower ribs are covering the abdominal cavity 10 to 12. So if the patient has lower rib fractures, always think of potential intra-abdominal organ injuries, commonly with the liver lacerations or splenic injuries. Okay, there are some pitfalls. Always remember, simple pneumothorax, patient may be okay on admission. Just a pneumothorax, you take it lightly, and while you prepare, this patient may go into a tension pneumothorax. Plus, if the patient is given positive pressure ventilation, easily these patients can go into tension pneumothorax. So always anybody with a significant chest injury before intubation and ventilation for any type of surgery requires a prophylactic IC tube. Then diaphragmatic injuries, or there's a high risk of missing diaphragmatic injuries, as we have discussed. Always remember to look for them actively. And pain control is one of the most important things. Extremes of age and comorbidities, those patients, the chest injuries should be managed very aggressively, because longer you wait, greater the risk of complications, hypoxia. Then whatever you do, very difficult to get them back. Over resuscitation, I have highlighted the importance of not over resuscitating patients. And chest tubes, I think during the appointment we would have discussed with some of you the risk of tube getting misplaced, how to identify, how to recognize the correct placement, what is the correct placement, etc. Those are some of the things you need to learn during the appointment. Okay, the same patient that we discussed, young man after high-speed motor vehicle accident with a low blood pressure, heart rate 110, GCS 15, very high risk of having a significant chest injury. So we need to assess according to the way we discussed and identify whatever the problems he's got, and then deal with them accordingly. Right. So that is the breathing part. Any questions? Okay. If there are no questions, so remember chest injuries are very common. So after assessment of the airway, breathing is the second part. You need to identify whether they are immediate life-threatening injuries, then you need to deal with them then and there. If not, you do additional adjuncts. The chest X-rays, fast scans, ECGs, ABGs, etc. to identify other 8 potentially life-threatening injuries. If any of those are there, again, you need to do the necessary things to ensure the patient doesn't develop immediate, intermediate, and long-term complications, and ensure the breathing is corrected. Right. So now we have discussed airway, we have discussed breathing. Third one is circulatory problems of shock. So shock is inadequate tissue perfusion. I guess you all remember from your first year physiology. Due to inadequate volume of blood, the tissues are not getting perfused. It could be absolute or it could be relative in a patient like, for example, anaphylaxis or septic shock. But in trauma, we are not expecting either. So in trauma, it's almost always hypovolemic shock unless proven otherwise. So think of a scenario like this. Again, this time a young female, high-speed motor vehicle accident, tachycardic, tachypneic, and hypotensive. Patient is confused and anxious. So there could be a problem with either breathing or circulation in this patient. So these are the things that you need to be able to cover, define and recognize shock. I guess you know what shock is, but recognition is one thing that you need to learn. Correlate patients' clinical signs and a degree of volume deficit, that is classes of hemorrhage. Early identification and control of the source of hemorrhage, you need to know. Describe the initial and ongoing management on patient with shock, physiologic responses, and when to give blood. When to give blood, how much blood to give, and what type of blood to give is are some of the other things you need to know. Shock, we have already discussed. In shock, what happens is generalized hypoperfusion. So there is an inadequate oxygen delivery to the tissues. So body will try to compensate by various mechanisms. One is there is a excessive catecholamine secretion, that is adrenaline and noradrenaline, causing peripheral vasoconstriction and tachycardia. So peripheral vasoconstriction will stop the blood supply to non-vital organs. At whatever the cost, body will try to maintain circulation to the heart and the brain at the expense of other organs. However, if the body can't maintain, then the tissues will go into anaerobic metabolism. That is something that you can detect with the arterial blood gas. You will find the patient is acidotic, plus there is an elevated level of lactate. So cellular dysfunction and cellular death are the ultimate effects of hypoperfusion due to hypotension due to bleeding. So that is what we need to identify quickly and correct. The question is whether the patient is in shock. Remember, there are no classes of shock, right? There are classes of hemorrhage. Shock is a yes or no answer. Either the patient is in shock or not. Shock is inadequate perfusion. If the question that you need to answer is, are the organs adequately getting perfused? So, okay. So these are some of the things that you may look for. Level of consciousness, like the patient that is described, that is due to inadequate cerebral perfusion. But having said that, this could also be due to a head injury. The patient will have cold, clammy peripheries because now the peripheral shut down due to catecholamines. Tachycardia, again due to catecholamines. Tachypnea and shallow breathing. Patient is trying to breathe more and more because the patient is now hypoxic. Tissues are hypoxic. Blood pressure low, obviously, because there isn't enough volume to maintain blood pressure. So kidneys are not getting perfused. So the patient will have a decreased urine output, which will take some time for you to detect. Next question you need to answer is, what is the cause of the shock? So I told you in trauma, most of the time, it is hypovolemic shock due to blood loss. But having said that, in patients with, for example, burns, it could be fluid loss, not blood loss. It could be fluid loss due to the burn injury. But on the other hand, there are other causes of shock. In a tension pneumothorax, the heart is not getting blood back because the great vessels are kinked. So this is an obstructive type of shock now. Cardiac tamponade, the same. The pericardial cavity is full of blood. The heart is not getting enough blood to pump out. Then cardiogenic, a crush injury to the heart, or maybe a stab or a crush Heart is not no longer functional. Patient is in cardiogenic shock. Neurogenic and septic shock are not so important in trauma situation. Neurogenic is if the patient has a spinal cord injury. Septic shock should not see in acute trauma. So what is the cause of the shock? This is what I've already mentioned. In a vast majority, it is blood loss. Right. The blood bleeding, as Abhijit told you, there are 5 main sites of bleeding. We call it 1 on the floor and 4 more. You may see the patient is in a pool of blood. So there is external bleeding, or there could be internal bleeding without a drop of blood outside. So there are 4 places where the patient can bleed: chest, abdomen, pelvis, and long bones. Don't come and say hypotension is due to intracerebral bleeding, right? So even last group at the Viva, my co-examiner asked them, okay, patient is brought after trauma, hypotensive. Then the discussion went to bleeding. Where is the bleeding? Intracranial. Unless you have a very big head with a tiny brain, you cannot lose blood to cause hypotension intracranially, because cranium is a tiny space. The bleeding will never cause hypotension. So remember, intracranial bleeding will never ever cause hypotension due to hypovolemia. Right? I hope you all don't have so tiny brains. So for that to happen. So always remember the potential places are chest, abdomen, pelvis, and limbs, long bones, especially the thigh. Plus, there could be bleeding outside. So those are the 5 places we need to look for if the patient is hypotensive due to and you're suspecting hypovolemia. Chest X-ray will tell us whether there is bleeding inside the chest, that is hemothorax. Pelvic X-ray will tell us whether there's a pelvic fracture. Very rarely only somebody will bleed into the pelvis without a pelvic fracture. Fast scan will tell us whether there is bleeding inside the peritoneal cavity. We look at the pelvis, upper left and right quadrants. Those are the places where they would bleed. If none of those are there, bleeding is excluded. And if the patient doesn't have a fracture and bleeding outside. So that is how you assess the site of bleeding. Okay, so you have diagnosed shock. The patient is hypotensive, hypovolemic, and their tissues are not getting adequately perfused. What should we do? Is the next question. If it is due to bleeding, the most important thing is stop the bleeding. Right? When the tap is open, no point in trying to fill the tank. So if the tap is open, close the tap. Remember, what you are losing is not only blood. It is not only the RBC, because we are giving packed red cells. You are losing blood, platelets, white cells, and clotting factors. We are losing everything which are active. Whereas when you are giving blood, you give a pack of blood which had been kept in the refrigerator, which is devoid of all these things that we have discussed. So prevention of bleeding is the most important thing. If a patient has an open wound that is bleeding, direct pressure, apply direct pressure, pack, or you can apply a tourniquet. I have sent you a video on how to pack a wound or control, apply local pressure. Hope you all have seen that. That is the way to pack a wound or control bleeding if the patient is bleeding from outside. Or you can apply a tourniquet. Now there are ready-made tourniquets which you can apply within a few seconds to control bleeding if the patient is bleeding from a limb. If the patient has a pelvic fracture, unstable pelvic fracture, what we do is we reduce the pelvic volume by application of a pelvic binder, either commercial one or just a GS towel. Then hemostatic resuscitation. Again, Abhijit mentioned, we don't try to increase the blood pressure a lot. We try to maintain the systolic around 90. So that will minimize the risk of bleeding. Plus, rather than just giving saline or other fluids, we try to give blood and platelets and FFP in the ratios of 1 to 1 to 1. So that will minimize any changes in your coagulation. Plus, if you have access, we can do angioembolizations, splinting of fractures, long bone fractures. Just splinting alone will control the bleeding. Plus, a commonly used drug nowadays is antifibrinolytic agents to control bleeding, tranexamic acid. So tranexamic acid in most situations will reduce the amount of bleeding. So all these are things that we do for patients who are in shock due to bleeding and hypovolemia. So before you give fluids, these are some of the things you need to think of. What fluid to give, from where are you going to give the fluid, how much fluid to give, and how to assess the response, and what are the potential pitfalls when you are giving fluids, for example, hypothermia. So these are some of the things quickly that should go through your mind before we give any fluids. Right. So balanced resuscitation, just know the concept, accepting a lower than normal blood pressure. For a normal adult, we say the blood pressure should be 120/80. But in a patient who is brought after trauma, systolic blood pressure of 90 is more than enough. That will ensure the organs are adequately getting perfused. At the same time, it will minimize the risk of bleeding further. And I have already touched upon the topic of transfusion or balanced transfusion. That is, you transfuse from the beginning, not only blood, but FFP and platelets as well. And in a patient whom suspect has lost a large volume of blood, you would activate what you call a massive transfusion protocol. Massive transfusion protocol, the moment you activate it, from always you give blood, platelets, and FFP together, never blood alone. Again, I need to highlight again, none of these are substitutes for control of bleeding. Right. So once you start resuscitating the patients with fluids or blood, whatever, what are the responses that you would look for? You look at pulse, you look at blood pressure, you look at peripheries, you look at the adequacy of organs getting perfused, improving the level of consciousness, and if you can do another blood gas, that should show a reduction in the lactate levels. All these will tell you the patient is responding. But having said that, there are different types of responders. Somebody who has lost maybe a liter or two of blood, who is no longer bleeding, will respond with your initial resuscitation and then will maintain. That is what you call a rapid responder, because the amount of deficit has been corrected and then the patient is able to maintain that. Somebody who is bleeding continuously at a rate that is lower than the amount of resuscitation you have been doing will respond initially, but the moment you stop, again will start deteriorating. That is a transient responder. That is somebody who is continuously bleeding. That is somebody who needs further interventions to control bleeding. A non-responder is somebody who has either lost a large volume of blood or who is bleeding at a rate that is greater than the rate at you are resuscitating the patient. So non-responders are the most difficult group of people, obviously, to resuscitate. Then classes of hemorrhage. I hope all of you all know the classes of hemorrhage. Class 1, 2, 3, 4. These are not classes of shock. These are classes of hemorrhage. 1 is less than 750. 2 is 750, 1.5. 3 is 1.5 to 2 liters. 4 is more than 2 liters. So class 1 hemorrhage is like a blood donation. You go and donate a unit of blood. That is a class 1 hemorrhage. They don't give you blood once you donate blood, obviously. So therefore, you don't need blood for a class 1 hemorrhage. Maybe some crystalloids alone is enough. You will have minimum changes. No tachycardia, no hypotension. You are otherwise going to be normal. Class 2 hemorrhage, it's more than that, 15 to 30% of blood volume lost. So you might be anxious. There may be tachycardia, but the pulse, blood pressure is more or less going to be normal, although with a decreased pulse pressure. The gap would be reduced. There may be a bit of a tachypnea, but urine output again is going to be normal. So unless the patient is bleeding continuously, this is another situation where a liter of crystalloid is all that you will need. But classes 3 and 4 hemorrhage, patient has lost more than 30% or a third of the blood volume. Patients are going to be confused, anxious, tachycardic, tachypneic, and hypotensive. So these are the patients who will require blood. So remember, anybody with hypotension, therefore, now classes 1 and 2 hemorrhage, the blood pressure was normal. Although in class 2 hemorrhage, there could be a low pulse pressure. So in other words, anybody with a low blood pressure on admission has a class 3 or more hemorrhage if the blood pressure low, hypotension is due to bleeding. So there's no point in just giving more and more crystalloids. This patient requires blood. Remember, therefore, anybody presenting with a hypotension after trauma has a class 3 hemorrhage, therefore needs blood. As simple as that. So don't waste time. So you may start off with 1 liter of normal saline, but not more than that. Then the patient should be started on blood, right? Give blood, try to identify the site of bleeding, 1 on the floor and 4 more. Look for those 5 sites and then try to arrest the bleeding. If it is a limb, tourniquet, packing, etc. If it is a chest, IC tube followed by thoracotomy if the patient is still bleeding. Abdomen, bleeding in the abdomen, the patient has to go for a laparotomy. Bleeding in the pelvis, apply a pelvic binder, see whether the patient is controlling. If not, need embolization or surgery. So it's fairly straightforward. But important thing, crystalloids, blood, then control the bleeding. More than 2 liters of hemorrhage, more than 40% hemorrhage, the patient will be, very, very confused, lethargic, hardly moving, hypotensive, tachycardic. These are just patients just about to die, right? Don't wait again. Immediately non-cross-match blood. Right? Don't wait. Don't try to do anything. Activate massive transfusion protocols. Get the blood as fast as possible and start pumping in blood. If you're not sure what's happening, rush the patient to the theater and do something about the control the bleeding. Minutes matter or seconds matter in this situation because the patient will be dead within a few minutes if you don't actively deal with this situation. Right. At the same time, there are other special considerations of what you call pitfalls when you're giving blood in an open environment. Patient is exposed, maybe air conditioner running. Patient has a high risk of developing hypothermia. Cold blood, cold IV fluids, air conditioning, patient exposed. Patient cannot develop, produce enough heat. Patient will go into hypothermia. You are giving blood, if you are giving especially blood without clotting factors, patient will go into a coagulopathy. Hypothermia further exacerbates the coagulopathy. Now, when there's a hypothermia, hypotension, tissues are not getting perfused, patient is going into anaerobic metabolism and producing acid. Lactic acid. Lactic acid causes lactic acidosis. Lactic acidosis causes a coagulopathy. That causes more bleeding. Further hypotension and hypothermia. So this is what you call the lethal triad. Hypothermia, coagulopathy, and acidosis. One worsens the other. So you need to address all three simultaneously. Correcting one alone is not going to correct the problem. So if the make sure from the time of admission, give warm IV fluids, keep the patient covered, increase the room temperature, never switch on the AC when there's a patient with a significant trauma inside the resuscitation room or the theater. Keep them, you might set, that is okay, but make sure the patient is never become hypothermic. Give blood clotting factors right from the beginning, especially if you are doing a massive transfusion, and make sure the patient's blood pressure and blood pressure is maintained with adequate perfusion to minimize the risk of acidosis. So evaluation and management of shock, there are again pitfalls like equating blood pressure with cardiac output. May not be, especially let's say somebody who has been on again, blood pressure, different age groups have different blood pressures. Older patient with somebody who has been hypertensive with a normal blood pressure of 180 by 100, you cannot be satisfied with a blood pressure of 90 by 60 because his organs are not going to be perfused. Whereas somebody whose blood pressure had been with 100 or 120 systolic by, let's say, diastolic 80 or 70, 90 blood pressure is adequate to maintain peripheral tissue perfusion. So, the blood pressure is a production of both peripheral resistance and cardiac output. So, blood pressure is not directly related to cardiac output only. So, it depends on the peripheral resistance as well. So, other thing, remember hemoglobin and hematocrit levels, these will take time to correct. So, when somebody has lost about 4 liters or maybe 2 liters of blood, when you take a sample of blood for hemoglobin, that is going to be normal. It will come as 14 or 15 because there had not been enough time for fluids to come into the vascular compartment. Patient has just lost blood, but the concentration is still the same. Remember, in a patient who has been just brought after trauma, even if the patient has lost few liters of blood, hemoglobin is going to be normal. It will take several hours for the hemoglobin to drop. So never try to equate hemoglobin to blood loss in a patient with acute bleeding. That's an important pitfall that you should not fall into. Okay, remember again, going back to the scenario, young female after motor vehicle accident, tachycardic, tachypneic, and hypotensive, conscious and anxious, confused and anxious. Most likely the patient is hypotensive in hypovolemic shock now. That is why confused and anxious. Confusion is due to inadequate brain perfusion. So after confirming the airway and breathing is okay, we need to quickly correct these patients circulation. You see the blood pressure is already 96/70. So patient is hypotensive. That means this is at least a class 3 hemorrhage. So we need to, while we give 1 liter of normal saline, we need to get blood. At the same time, we need to identify the site where the patient is bleeding from. So therefore, all things should happen simultaneously. That will make sure the risk of patient dying or developing complications due to hypovolemia shock is minimized. Okay. So this is the last slide. Shock leads inadequate organ perfusion and tissue oxygenation. We discussed hypovolemia is the main cause. Diagnosis and treatment, like everything in airway, breathing, circulation must happen simultaneously. When to suspect and how to suspect and how to identify problems with circulation, we have already discussed. Remember, early blood is one of the most important things. At the same time, other new concept that you need to remember is balanced resuscitation. Never try to achieve a blood pressure of 140 or 120 in these patients. That should not be the target. That will increase the risk of this patient bleeding further. Our target should be 90 or 100 systolic blood pressure, or what you call balanced resuscitation. Those are the two most important things in relation to circulation you need to learn. One thing is balanced resuscitation. Second thing is early use of blood. Okay, that's all I have to tell you. Are there any questions? I went a little fast because we were kind of running short of time. Are there any questions? Any area from the area Abhijit discussed or from the areas I discussed? Initial assessment, primary and secondary survey, that is airway, breathing, circulation. That is what we covered during these 2 hours. Are there any questions? Okay, hope you all are still awake. So if there are no questions, thank you.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.